This is Lois Whaley for Women Today and Yesterday. I have two guests today. They are both from Span, Ohio. Let me introduce first Arlene Sheak. Arlene is the local person for Southeast Ohio for Span. And our other guest is Debbie Silverstein from Columbus. She's returning to the show. We had her on a couple of years ago, actually. So she is the CEO for Span, Ohio.
Well, thank you, Lois. It's a pleasure to be here, and thank you for having us.
So I might add that I'm beginning my 9th year for Women Today and Yesterday now in September, because I began in 2006.
Wow.
So it's been a while, and I've had Arlene on my show before also. Thank you, Arlene.
It's a pleasure to be back.
Span, Ohio. Now, Debbie, what do we mean by Span, Ohio?
Span, Ohio stands for Single Payer Action Network of Ohio, and we propose and advocate for a single payer system of healthcare. And that's really just one aspect of what we're advocating for. That would be the financing part of it. And that means that we would all pay into the system, and one entity, the government or an agency that we would choose, would pay all the bills, instead of to hundreds of different insurance companies with 10,000 different products that they sell and have to be administered and that type of thing. So it would simplify the system and bring it into, where just one entity is doing it. That's the way Medicare works. Most people are familiar with Medicare.
Medicare.
Yeah, and with Medicare, what happens is your employer pays 1.45%, you pay 1.45%, and then when you're 65, you've got health care coverage. And that money is going into the government, and then the government pays out when you have a claim. And that's what we want to do.
Single payer.
Single payer. Yes, it's a simplification of the system that we have. Well, right now, you have to think about what we do. We've got many different systems. We don't have one unified system.
Yes.
We've got many, many different systems. We've got Medicare, we've got Medicaid, we've got Medicare Advantage, we've got the VA, we've got TRICARE, we've got the Indian Health system, we've got private insurance, the individual market, the group market, employer-sponsored insurance, self-insurance, third-party administration. And what it is it creates something like this, and it's an absolute mess.
Wow.
Just an absolute mess. But, I think even the creators of the chart probably left some of it off. And then when we look at the ACA did nothing to fix this part. The ACA complicated things even further.
The ACA?
Yeah. People have gotten coverage, but what's happened is it was so complicated for people trying to choose these insurance policies that what happened was they had to add another layer in there. They had to have navigators to help people figure out which policy was the best and how to work the web pages, and they had to have certified application counselors that could work with them on choosing these policies and getting them signed up. And that type of thing. So this situation was just exacerbated.
Yes.
By the ACA rather than simplified. Now, some people, yes, did get coverage, but
Lois, I might add the ACA. We refer to the Affordable Care Act,
yes,
which is commonly known as
Obamacare. Yeah, and I tend to refer to it as the ACA.
Right.
The Patient Protection and Affordable Care Act. There are some patient perfections in there. Not a whole lot of affordable care, unfortunately, and stuff. But the complexity of our healthcare system leads to a situation like this.
Oh, dear. What is that? My goodness.
Well, this shows the growth of physicians and administrators.
Administrators.
Administrators in healthcare from 1970 up to 2010. And the physicians are this little dark blue band across the bottom.
Yeah.
And the brownish area, that's the growth of administrators. And you can see, we didn't really have a lot of administration taking place back in 1970. And then the real boom was in 1990. And that, when they really went up. And that, and that's where our money's going. This is what we're paying for because of the complexity of our system. Rather than paying for actual care, we're paying for administration.
Yes. Yes,
So-
and that certainly means that it's more expensive than one would think.
Yes.
Oh, yes, a lot more expensive. And what happens is we see this, where when we look at the percentage of the gross domestic product, which is, something that we can compare between countries, and we're looking at what percent do we pay compared to what percent do other countries pay. We're that white line at the top, and we are paying almost double what other countries are paying. We're paying in this, we're definitely past the 17% now, heading towards 18% of our gross domestic product, whereas other countries are in the 8, 9, 10, 11% range. And the thing is, people need to realize what that does to us economically as a whole. It's not just affecting us as far as healthcare is concerned. When we're spending that much on one sector of the economy, then
Yes.
it has a tendency to squeeze out other sectors of the economy.
Yes.
Now think of this. If you have high healthcare bills, where does your money go to? It's going to pay for the health care, and you skimp on other things that you might purchase, things like new pair of shoes, clothing, a vacation, anything along those things, something, household goods and that type of thing. No, we can't do it. No, we're not going to have steak. We're going to have beans and rice and that type of thing till we get this bill paid off. The money is going into health care. It's not going into other goods and services.
Right.
And that, which affects those industries.
Yes.
I might add, Lois, that researchers have found that in our total economy that it's over $475 billion that is going to support this bureaucracy, which is not giving us any real benefit in health care, and that when other countries are spending half of what we spend, they are also covering everyone in the country. And so the money that goes into this excess of paperwork and denials and profit making could be both covering all the people who are not covered and adding more for the people who have coverage, costing us less personally and as a nation.
Yes. Well, Arlene and I go way back.
Yeah.
And I can remember meetings, Arlene, with you and Bob Smitty.
Yes.
I think it was over there at the old Rural Action headquarters.
About 12 years ago, way
Long
back.
time ago. Bob has passed on, unfortunately.
Yes.
But we were talking single payer at that time, Debbie, and it's interesting to me. I mean, one of the first things that happened after President Obama became president, one of the first things was that he called a meeting about health care.
Yeah.
That was just a month or two into his administration. And I heard that single payer was not on the table. And I thought, what? We've been talking about single payer for years and years, and it isn't even on the table.
We've been talking about it, but elected officials necessarily have not been talking about it, with the exception of a couple. And that. But he never ran on a platform of single payer, and a lot of single payer advocates thought they were hearing that from him, and they weren't. He never ran in that election saying that he wanted a single payer plan. He ran on the plan for a public option, which he didn't get, and my disappointment was that he gave in too soon on that, but never single payer. And they said, well, he said he was for it. Well, that was years previous. That was not during that election.
Yes, I think he said if we were starting from
all
scratch.
Over. Now, you have to
all
understand,
over.
too, the politics, the way politics works. If he had run on a single-payer platform, he most likely would have not just been running against John McCain, but also every insurance company in the country.
Yes.
And that type of thing. And, he probably felt he needed to win in order to do anything, first of all. And then we could see how far we could go. And politics is not, what takes place in Washington is not as altruistic and pure and well-meaning as most of us think. There's a lot of backdoor scheming that goes on, and there's nothing clean about it. You really have to follow the money on it. And in this case, you needed to follow the money of the insurance companies. If you look at who wrote that bill, it was written by Liz Fowler, who used to work for WellPoint, who then came on to work for Max Baucus, who wrote the bill for him. And so definitely it was written by insurance companies with the needs of insurance companies in mind, much more so than the needs of the individuals. And that's one of the things, politically we need to change that. We need people to be engaged politically. The reason things are the way they are is because people have become disengaged. And they need to engage politically. They need to hold their elected representatives accountable. They need to be constantly in contact with them. And the way you get what you want from them is that you make it easier for them to give you what you want than to put up with you all the time.
Right.
And
And then I'll tell you what, that advice comes straight from Senator Sherrod Brown's wife, Connie Schultz. Be the burr in their butt and that type of thing. But so looking at that, what we're looking at here is we need to change the way that is done, but we also, we need a massive grassroots movement in order to get this job done. Our politicians and our elected leaders are not going to do it unless we force them to do it. And so what SPAN is working on right now is we want a healthcare system that meets human rights standards. We want it to be universal, which means if you're everyone is covered. If you are breathing, have a heartbeat, you're a human being, you're covered. Okay? Totally universal, so that it's not dependent on jobs, financial status, social status, marital status, any other kind of status that we can dream up.
Right.
It needs to be equitable. It means that everyone needs equal access and equal availability, that the resources have to be there for people where they are, that the program and the treatments need to be appropriate to the needs of the patient, not what the insurance company will allow or say you have to do before you can have the appropriate treatment, which we see quite a bit these days. And it also has to be financed in a fair and non-discriminatory way, and that's what single payer is. Right now, the way the system works, the lower your income, the more the burden healthcare is to you. And healthcare is a basic human need, and so we need to look at that so that people aren't burdened with unnecessarily or unfairly in the process of staying alive.
Right.
And that the poor and the middle class are not losing their homes because they get sick. And that, so it needs to be universal, it needs to be equitable, it needs to allow for the participation of the patient in making the rules, and it needs to be accountable to the patient, not Wall Street shareholders. And those are the changes that we want to make. And so this is what we're looking at, what we're proposing. And knowing that it needs a really, really strong grassroots movement, SPAN Ohio is embarking on a 5-year base building plan to really build that grassroots so that we can force the hands of those who are elected to truly represent us.
Arlene, I know you're one of our grassroots persons here locally, and how many like you are there around the state?
Well,
in other areas?
SPAN has 7 regions, and we have a website I'd like to share so that viewers would know that no matter where you reside in Ohio, that there's a connection to a person who, like myself, is a volunteer as a regional coordinator. And I'd like to go back to an important point Debbie made about how we have to hold our elected officials' feet to the fire, so to speak, to get things done, and say that SPAN is involved throughout the state getting signatures on letters to our individual state representatives and state senators, and that we want them to know how strongly our population feels about having fairness and universal coverage in Ohio, and we hope that everybody over 18 will want to be registered to vote and to participate in the system. We all make complaints, but if we don't register to vote and cast our ballots, we don't get a voice. And the SPAN Ohio website also shows activities going on throughout the state, and we do have a state council over which Debbie, as our state director, presides, and we meet at least 4 times a year, and we have a conference that comes up in the springtime in April that we would invite everybody to come learn with us and participate and help us truly build our base.
Yes. Well, you know, I'm a historian, and so I think about things that happened in the past and sometimes in my past. And one of the things that happened in my past was that in 1956, which is a long, long time ago now, almost 60 years, we were living in England. And England already had National Health Service.
Right.
And one of the things about it that was very good as far as I was concerned as a foreigner was that even foreigners were a part of the people who could receive services. It so happened that that year I had a problem, one of those female problems that required some surgery actually. And I had that surgery. It was interesting, and I remember waking up, you know, in a place, a hospital, where there were about 40 beds, you know. And I was one of 40 women who had had a similar operation that day. I mean, it was amazing. It was really a sort of a, I don't know that usually happens, but it was almost like a production line. You know, I guess I was lucky in being early in the morning, but they were doing those operations all day long.
And how did you feel about the care you received and the billing?
Well, I certainly, you know, was surprised to see I was one of 40 or whatever, and then of course about 6 weeks later in the follow-up, I was sitting in a long line of women, and actually I was waiting next to where a doctor was talking to a woman whose prognosis was not good. And I thought, oh, you know how that is, and so on. But he told me that I was doing fine. And
you know, back in those days, we had the big wards here in the U.S. and that type of thing. That was not typical of England because they had a national health service. It was just the way we did things all over. Because you know, I can remember as a child being hospitalized, and it would have been about 1957. And it was a huge big room, and there were about 12 of us in there, which was okay when you're a kid because you want to play.
In a crib, no doubt.
Yeah, in a crib, even though I was 4 and I had a big girl's bed at home, and that. But you know, you didn't have the private rooms, whereas now they're tending to go towards all the private rooms for privacy's sake, and you know, we've changed things. But that was also back in the day when everyone knew the patient's condition except the patient.
Yeah.
You know, you remember those days, you know, that you didn't tell Grandpa. We were not allowed to mention Hodgkin's disease around my grandfather. He had Hodgkin's disease, but everyone knew it except him. He was never informed. And it was like, that makes no sense whatsoever, that everybody else knows he's got Hodgkin's disease except him. Well, they didn't want to upset him and take away hope and that type of thing. We've come a long way since then with patient rights and that, and in the way we treat people, with, you know, some exceptions. You know, we are still, in this country, you are a revenue source before you are a human being in need of care.
We talk about wallet biopsies for admissions.
Well, you know, it's like the Cleveland Clinic. I'm sure some of your viewers have heard of the Cleveland Clinic. The Cleveland Clinic will not make an appointment for you if you don't have insurance. You have to meet with a financial counselor first. They're going to make sure they get their money out of you. And if you call and make an appointment, you can have the most serious conditions and symptoms, but they want to know about your insurance first. And if you pass that hurdle, then they'll be concerned about your symptoms. You know, and I did that a number of years ago, and once I passed the insurance hurdle, she asked about the symptoms, and I started rattling them off. She says, "Oh my God, we got to get you in here right away." I said, "Yeah, that's what I was trying to tell you before."
Yeah.
And
Yeah.
Debbie, maybe you can contrast this. Debbie had a very interesting experience in another country where it was the opposite.
Right. Yeah, I thought I had broken my foot. I was visiting my sister who was living in France at the time, and I thought I had broken my foot. We went off to the ER, and when I said, you know, I fell, I think I may have broken my foot, their first question to me was, "Madame, when you fell, did you hit your head?"
Yeah.
Then they want to know about elbows, knees, everything else. And they never once asked me about payment or anything. So when I was leaving, I said, "Well, how do I pay for this?" And they, "Oh, Madame, you don't pay."
So they have provision for foreigners as well.
Yeah, well, the way they do it, that you know, it would be harder for them to collect payment from me than it is to just let it go. Because the way they do it is they have global budgeting for their hospitals. It's not on that fee for service, you know, type of thing, you know, where they charge for every single thing they do. They handed you a Kleenex, that'll be $20. They gave you an aspirin, that's $35, that sort of thing. It's just a global budget where the hospital gets the money they need to operate during, you know, the year, the quarter. They might do it on a quarterly basis or a monthly basis, and you go on and you take care of whoever comes to your door. You don't get any more for taking care of them or any less if you don't. You know, it's you're going to get the money you need to operate. And hospitals, most of their expenses are fixed expenses, and they can easily estimate the other ones from previous experience and that type of thing. So it makes sense. But it also makes them sit down and do some global budgeting, which we don't do here because we don't have a unified system. There's no way we can do a global budget for health care, you know, or any kind of a budget for health care in general because we don't have any kind of a unified system. We have that mishmash I showed you earlier.
Right, well, in every state, we have 50 states in our federal system.
Right.
And every state may have somewhat different services from some other.
Well, they have different needs as well, because like you go out into some of the southwestern states with high Indian populations, and they've got the needs that they have to take care of them through the Indian Health Services, and there's concerns there about what happens with this and that and the other thing. So a lot of issues that are because we don't have that unified system.
And one of the local mishmashes, as you aptly put it, Lois, is that a small hospital like we have here in Athens a few years ago had 125 different ways to bill a syringe. All the policies, it's just amazing how discombobulated things are, and the number of people involved in billing compared to the people in actual health care. And Debbie has some updated information on.
Well, a few years ago, a Broadway actor came through with a play that he had written here to Athens, Mercy Killers, and I don't know whether you got to see it when he was here or not, but he's researching for a new play now, and he contacted me. He says, there is a statistic about the number of, insurance company people per, and that kind of thing. I said, well, I think you were talking about this statistic. Duke University Hospital had 900 beds and 900 billing clerks.
Wow.
Because that's what it took. And he says, yeah, that's it. I said, let me check and see if that's still valid, because that's a number of years ago that was. So I started checking, and I got more up-to-date figures. It got worse. 900 beds, 1,200 billing clerks. The system just keeps getting more and more and more complicated. When I worked on the Medicaid expansion in the coalition, we were one of the first coalitions up in Northeast Ohio. And I sat around the table and I thought, I don't know how these people keep this straight, and how they keep their heads from hurting, because they were talking about, well, you've got the Medicaid, the previously eligible, the newly eligible that come in at a higher rate of federal support. You've got, these are the requirements for the previously eligible. Can we move some of the previously eligible into the newly eligible? And then you've got the dual eligible for Medicaid and Medicare, and then you've got Then you've got the dish payments and the HPAC payments, for those that can't pay at all, to cover up some of the charity care, pay for that type of thing, which is all tax dollar money, keep in mind, and stuff. And I'm just sitting there, and my eyes started to roll in the back of my head. I said, how do you keep all this straight?
And another angle of having a universal single-payer system is in fairness to our healthcare providers who have all of these many payments, and instead of a typical doctor's office just having 1 or 2 pieces of paper to submit for patients, every office has to have billing clerks for even a couple practitioners together, and now we find them, getting in bigger systems to care for all the complexity. But we also find that in our current system that providers will not necessarily be paid for every individual to whom they give service. And in one of our recent reports from our local hospital, it said that they gave $8 million in charity care. Well, that is not right. I mean, that somebody is paying for that, who are having the insurance and making those insured rates higher. And if we had a system where the provider was receiving payment for services given, that would just make for such a fairer system.
Yes.
A lot of people will expect a doctor to give free care because they make a lot of money anyways. But they have to understand they don't expect that of the plumber or the electrician.
No, that's true.
And, this is his livelihood or her livelihood, and this is, they need to be reimbursed for the work they do. They went into this so that they could make a living. And most of them make a very good living. There's no doubt about that. And I don't have a problem with that. There's some of them that could do with less, some of those really high-priced specialists, and that you see when you're in those pay or die situations, and that. But for the most part, I don't have a problem with the providers, especially the primary care for providers. They really deserve more than what they're getting, and that. I have a problem with the waste that goes on, and with that amount of waste, we could be covering every single American. We could cover everyone in this country and leave no one out. I have a problem with a system that leaves people out. How do you make that decision? Who are you going to leave out? Who would you leave out? You got to leave out 30 million. Who are you going to leave out?
They had Medicaid to cover the indigent.
Yeah, but not all states expanded Medicaid.
No, that's true. In fact, Ohio is lucky that our governor asked for it.
Yeah, and that only came up to 138% of poverty. But if you really know what that wage limit is there,
it's very low.
It's very low.
No.
If you're below what they consider 200% of poverty, you can't survive without some sort of assistance. Okay? So the people between 138 and 200% of poverty, okay, they might be able to go on the exchanges and get a subsidy that pays the full premium, but then they can't pay the deductibles and the copays. That is a barrier to them that prevents them from getting care they need. Do you know, this is an interesting statistic. Ohio is number 3. Number 3. We're number 3. Maybe we don't want to be number 1. We'd like to be number 50 on this. We're number 3 as far as the number of very high deductible plans that were sold through the exchanges. The percentage of them. That we have sold more than all states except Texas and Illinois. Right.
In other words, you have to pay, say, $2,500 before you get any help.
And in a lot of cases, it's worse than that because
sure.
I went on the exchange to see what would be available to me because I was curious. I had done it the year before, and I was, like, oh, wow. There's nothing here that's affordable. I went on it last fall, and I'll do that again this fall, too, during open enrollment. The cheapest plan available to me last year during open enrollment was $500 a month premium, which was too much right there. Yeah. But it had a $6,300 deductible.
$6,300?
$6,300.
Wow. Yeah, well, that's when you begin to see how difficult the system is. And I'm glad you mentioned open enrollment because we're facing that again very
Right.
soon, right? Is it the month of November?
Yeah, I believe so. But you know, there was a lot of people suffered some other problems with that. My sister was able to get insurance through the marketplace exchanges. And when they first determined her eligibility, they said she was eligible for a fairly decent, subsidy of about $200 a month. So she had a policy. It was a silver level policy, and it was about $400 a month. So she was paying $200, and she got a $200 subsidy each month. Well, when she went to do her taxes for 2014, there was a problem because to determine the subsidy, that was done based on your 2013 tax returns because that's all the data you have. And during that year, she had a number of furlough days because there just wasn't that much business and that type of thing. But that didn't happen during 2014, and it was just enough to put her over so she wasn't eligible for that subsidy.
Oh,
so not only did she have to pay that subsidy back, $2,000 worth that she owed. Where they expected her to get it, I don't know. So she had to come up with $2,000, to pay off the government, pay back that subsidy, plus her insurance was now going to cost $200 a month more. So she called the insurance company to tell them that she was going to pick up that policy, the full payment of it, and they said, oh, well, if you're not getting a subsidy, you can't keep this. You can't go through the exchange. And I said, yeah, you can. But they wouldn't let her go through the exchange. They told her that she had to get a different policy, which cost even more per month than the one she had.
Does she live in Ohio?
She's in Michigan.
She's in Michigan. Huh?
Yeah.
And of course, things are maybe a little different there, but probably
Well, the market
similar.
is very, very similar. Very, very similar. And so, and I'm thinking, no wonder people are angry. No wonder people are confused. No wonder, we have complicated it to the point where we totally baffle people and we have them as victims in this system rather than meeting the needs of the people. But that goes back to who wrote it. The insurance company wrote it to meet their needs, not the needs of the patients, not the needs of the people that this healthcare system is supposed to be serving. So I would go back that we need a system based on human rights standards that is universal, that is equitable, that is transparent, and is accountable to the patient, not Wall Street.
Not the stockholders.
Those are the
Yes.
the things. Now, a very interesting development is in some states have come together and formed the Healthcare as a Human Right Collaborative, and you can visit their that webpage, and that's healthcareasahumanright.org, all one word, healthcare as a human right. And they've got a lot of good information about just what those standards mean when we're talking about a healthcare system. And I want to point out again, single payer is the financing aspect of it. But there has to be other changes that are made to our healthcare system so that we don't strip people of their dignity, and so that we don't lose our humanity in the process.
Well, I think that one of the things that I've heard is that doctors are expected to just, go right down the line, so many people, 15
minutes, yes.
15 minutes each,
yes.
And that's a sort of a top-notch thing, and you have some doctors that won't follow those rules, and good for them.
And some of them
some get fired because of that.
Yeah,
for sticking up for the patients. Well, we are fortunate in Ohio that Debbie is representing us in meetings of the 26 states that are working in some capacity to develop a single-payer system. And also, I might point out that for a long time, we've had in Washington House Bill 676 to have a federal solution, because long-term, this is what we want, for everyone to be covered. And I want to point out to people who view this before October 16 of 2015 that in Columbus, Ohio, on that October 16 Friday, that John Conyers, champion of everybody having coverage, more like Medicare for All system, will be speaking at the Trinity Church in Columbus, and there will be information again, on that website, SPAN Ohio, www.spanohio.org, and that we'd invite everyone to join with us that day.
That's October 16th in Columbus.
Correct.
Let me point out just a bit of interesting history here. Have you ever seen this, Debbie? This T-shirt? I'm a big T-shirt person.
Yeah, that's what I've
Yes,
heard.
that's a wonderful T-shirt.
Well, I knew that I got it a long time ago, but I couldn't remember when. I knew I'd gone to a health day in Columbus. And actually, I don't think it was as long ago as 20 years, but it does say down here that the probably woman who did this T-shirt did it 20 years ago.
In 1995.
1995, and that was Women's Health Day Columbus.
Yes. Well, yeah. And I know healthcare has been an issue, and to tell you the truth, this has been something on the national agenda since about 1912. So we've been going at this about 100 years now. And, maybe the ACA was the best we could do at the time. I'm not so sure. I know when Medicare was passed, and this is a real important point, we celebrated the 50th anniversary of the passage of Medicare this past summer. Medicare is one of the most successful social programs ever.
Yes.
Although there are attacks to do away with it, and they have been chipping away little by little at it, we as a nation, as a society, have to stand up and tell our elected officials, no.
Right.
You cannot do that to Medicare. Medicare is so successful. Before Medicare, only about half of seniors were covered. Since then, about 97%. And the poverty rate, seniors used to be the most likely to be living in poverty.
Right.
And now their poverty rates are the same as every other demographic, with the exception of children. Children are the most likely to be living in poverty at this point.
Yes, and of course they say that 40% of children have problems with health care coverage.
Absolutely. And, but the other part of, the Medicare thing is, when it was passed, it was a compromise position from a national health program that, we see similar to European countries and Canada.
Right, and begin with the old folks.
Yeah,
kind of
well,
thing.
we still felt kindly towards the old and the poor and the disabled back then. Nowadays, we hate them, and they're the cause, the root of all evils for some reason, and we victimize the victim, and stuff. So back then, we had a little bit more empathy and compassion for people.
Yes.
And so we passed that because that was the easiest thing to pass politically. But the intent was that they wanted to take Medicare and lower the eligibility age bit by bit, over time, and to take, there's the Children's Health Program and bring that up bit by bit until the two met, and we had everyone covered. But we never followed through on that.
No, we didn't, and what is more, it's gone the opposite direction.
Yeah,
They're
we tried to
talking about
exclude.
making Medicare and Social Security later ages than they are
and
currently.
there's no reason. They're manufactured crises with them, just like they've manufactured crises elsewhere. We underfund the public schools to make them fail so that we can privatize, not because it's better, but because there's money to be made. We have undermined the post office by requiring them to pay retiree health benefits 75 years in advance. No one can estimate them that far. That's just totally ludicrous. But the idea there is to privatize the post office because FedEx and UPS have a real powerful lobby. Follow the money. Follow the money. And so now we want to privatize Social Security and Medicare. The other day when the stock market dropped so much, what if your Social Security had been in the stock market instead? Where would you be? That's the thing. Social Security is dependable. The stock market isn't always. Yeah, you can make a killing. But people of modest means, and that's the vast, vast, vast majority of us, need something that is dependable and reliable. And that's what Social Security is. That's what Medicare is. There is, they cannot propose a private system that's going to do it any better than those.
And Medicare, Lois, costs between 2 and 3 cents on the dollar for 97, 98 cents going into real health care value as
Right.
opposed in our private sector where Debbie earlier mentioned that
All
could
those
be
administrators?
33% of our healthcare dollar gives us no value in healthcare.
Yeah, it's right here. This is what we're spending our money on rather than care.
The administration rather than the
Yeah.
than the doctors being that line down at the bottom.
Yes.
And
And
the
you can
brown
see that
being
what we're
the
paying the
decades.
doctors really isn't that significant compared to what we're paying for the administration of this highly complex system, convolutedly complex system. And so when people say, well, it's going to cost us a lot more money to do what you want to do. Yes, that's going to be tax money to do what we want to do. And for some reason, we're afraid of the word tax. If we call it a premium, it's okay. So you can take $200 out of my right pocket and call it a premium, and that's perfectly okay. And for the exact same thing or better, you could be taking $100 out of my left-hand pocket and call it a tax, but because it's a tax, it's worse.
Right.
You know, and that type of thing. One of the things that we do have to realize when we're talking about health care is it all comes out of your pocket anyways. You know, you are paying for the whole shebang. You know, you've got the individual household, you're paying taxes for Medicare and Medicaid, you're buying individual health insurance, or if you've got it through your employer, you're taking it in the health insurance in the form of lower salaries. You've got your out-of-pocket costs. You've got property taxes that are paying for public employees, and we should be, you know, because right now we've got an employment-based system. You know, we've got the health insurance for them, we're paying higher prices for goods and services because they have to, businesses have to cover health care, whereas in other countries that's not the case. You know, so we're at a competitive disadvantage, you know, because of that. And there's a lot more that you could put in here, but it's all going to come out of your pocket. So
Yes,
you
and-
decide how you want it. Do you want it to come out in that wasteful way?
Well,
Or-
I think, you know, Debbie, I think that one thing that some people don't realize is that Medicare is definitely something which you pay for
Right.
as an old person.
Yeah.
And I don't mean through taxes. You do pay through taxes as well.
Right.
However, you have quarterly payments to make,
You have a premium that you
a
pay.
premium to pay
Yeah.
quarterly,
And
and
that's
that
the way
adds
it's-
up. That
Yeah, and
adds up.
that's the way it's set up, and I'll tell you why they set it up that way. To make it easier to pass originally, to get it passed. Because they based it on, you know, what private insurance was doing at the time. And because they felt it was easier to get the votes, to get the passage to do that. So that's why there is a deductible, and that's why there is a premium and that type of thing. If you look at the national plan, we do away with those because you're paying, you know, you're going to pay once, and simplify things, make it easier to administer and easier to use for the patient and that type of thing, and that actually saves money. You know, then they were looking, one of the things they were looking at is, you know, there's the discussion about undocumented workers. We want to leave them out. They found it would actually cost money to leave them out.
Really?
Yeah, because you've got the administration that has to determine whether they're eligible or not, and then you're going to enforce, you know, force all of the providers to have ways of collecting the money from them.
And you're going to have people who are forced to go to the emergency rooms
Yes.
because they will not be included to have a primary care doctor.
Right.
And another way that we really disadvantage business and people in our rural area here is with the current workman comp system.
Oh,
that
really?
if we had universal coverage, how something adverse happened to your body or where it happened wouldn't matter. You would just have a card and you'd get services, and businesses would not be disadvantaged by this workman's comp that they have to do right now, and people living in Southeast Ohio would not be disadvantaged by being told that with their severe injury they had to go see a doctor in Columbus or Chillicothe or somewhere else who was part of the workman's comp system. They would go to wherever
Yes.
they
It
wanted.
wouldn't matter how the injury or illness came about. They would be covered, and they
Yeah.
would be able to get the care they need right here.
Right, they have to
Yeah.
determine whether workman's compensation would cover the medical costs.
But not with a universal
Right
system.
now.
There wouldn't be a
Yeah.
workman's compensation because you would have one system that covers everything. You know, so that wouldn't matter anymore. So employers wouldn't be spending time fighting things, and employees who are in need of care wouldn't be spending time begging for the care that they need and fighting their employers saying no, and that. You know, and something else that I did want to bring up is, and it's a thought. I saw that Jon Stewart, the comedian and talk show host, is leading a campaign to get better care for some of the 9/11 first responders. 14 years, and this is the 14th.
It's a long time, yes.
And this
Fourteenth
is
Today
9/11
commemoration.
today.
Yeah.
11.
Yeah.
14 years, some of them have waited and gone without the care that they truly need. Many of them have died because they didn't get what they needed and stuff. And we have a comedian who is, you know, leading the charge on this. You know, and it's kind of like only in America. Because if it was any other country, those people that rushed in to save others would not be waiting and begging for care. They would have had it.
Yeah.
No questions asked. And the rest of the people affected by 9/11 would have had it. No questions asked. But it's only in America that we make people beg for something that's so necessary.
Well, you mentioned Medicare, and I mentioned that I'm on Medicare.
Yeah.
My
And I am
husband
too.
We're
And my knees are waiting to be on Medicare.
Your knees will be on Medicare a little later on, maybe. Yeah.
2 years, 6 months, but who's counting?
All right. Yeah, but I want to warn people that they should get on Medicare as
Early
soon as they can.
as they're eligible.
This is something that we didn't realize because at the time my husband was still teaching, you know. And I thought, well, you know, we're paying and having money taken out for health care, so why should we pay for Medicare at this point? But what we discovered was that when he did retire, you know, this was like 5 or 6 years after he would have been eligible for Medicare coverage, the premium had gone up, and it never goes down.
Right.
So we have a rather substantial premium to pay because of the fact that we didn't begin the Medicare soon enough.
There is a penalty if you don't start it right away. Now, there's some exceptions to that penalty, and you really need to talk with somebody who's well-versed
Right.
in Medicare to see if you qualify for that. But I think actually having credible coverage through an employer is one of those exceptions, so that there shouldn't have been a penalty for you, and that. But
They
for
may
people
have
that
changed things
yeah,
since
for
then.
people that just wait to sign up, you want to do it as soon as possible because then there is a penalty and it does cost you more. But they do have some help provided for people that can't afford those premiums and you know, to offset that. I think what we need to do, though, is one of the considerations we need to do, people talk about, well, make the rich people pay more for it. But Medicare is kind of a unifying thing because we're all in it together, wealthy and
Yes.
poor. And as long as the wealthy are in it, they want it to be good. And we benefit from that.
Yes, of course.
You know, they're
need
not
to
going to
keep
settle
it
for
for
less.
everybody.
Yeah, you need that
Absolutely.
same quality for everybody.
Yes.
And it shouldn't be dependent on whether you're rich or poor. That's really a horrible way to ration care. You know, really it needs to be, do you need it or not? Not, oh, well, you're poor, so, you know,
We
we'll-
need to care about each other
Yeah.
and hold everybody
We aren't
in
that kind of
good
country where we
respect.
throw people by the side
And-
of the road. You know, we don't do that
Yes,
in
and as we
America.
can get near the end here, I want to again share the SPAN website for people that have joined us into the program, that Debbie Silverstein, the director of SPAN, and you can learn about our organization statewide in Ohio, www.spanohio.org.
I think that it's very good, too, that you pointed out, Arlene, that if they go to that website, it doesn't matter where you go in Ohio, you will get the name of the local person
Yes.
to contact. Of course, here in southeast Ohio, you'll be in touch with Arlene. But if you have relatives who live elsewhere in Ohio, and they go to the website, they will find a person who can help them.
Or maybe if you're viewing online, you are somewhere else in Ohio,
Yes,
and
that's
you
right.
can
Right.
see what's happening in your area.
Well, the other thing too is I'd like to invite your viewers to get actively involved with us. You know, we are setting a strategy plan. Our goal is to get this in Ohio by 2025. In order to do that, we have to provide our elected officials with some political will, and that only comes, you know, when the population, the grassroots, the people, the constituents force them, you know, into taking some action. So we need to build a really strong grassroots community that is going to be very active in lobbying our legislators and in also educating other citizens, and we're going to be focusing on that. And then we need to look at either getting our legislature to do something or putting it on the ballot. But it's time that we did that. You know, people, while some people have been helped, there are too many people left out, too many people that are in big jeopardy because of those high deductible insurance policies that they have, that leaves them very financially vulnerable if they should get sick.
Right.
You know, and that's what leads to 62% of personal bankruptcies and 49% of foreclosures. And that affects you and me, even if it's not us being foreclosed on, that affects our house values. So we all have a stake in this, and we really are all in this together. And so let's join together, let's make this a reality, and let's make sure that our healthcare system here in Ohio does meet human rights standards.
Arlene, will you show us again about the upcoming October 16th event in Columbus?
Yes, we are looking forward to John Conyers, who's now 86 years old,
My
who's been
goodness.
the stalwart leader for a national
Michigan
universal health care policy.
legislator.
Yes.
And we are going to meet at the Trinity Baptist Church in Columbus, and the address of 461 St. Clair Avenue in Columbus, and everybody is welcome, and you can check the SPAN website for the time. It'll probably be 7 o'clock in the evening.
They say 6:30 on there, so maybe that's
Yes,
when
gathering
they-
at
gathering at
6:30, yes. And it's an easy access building, and there is plenty of easy parking.
Great.
Oh, good.
Great.
Yes. Well, you know, I can recall, again, historically here, it must have been about 92. I think it was during that election year.
Yes.
There were big meetings, I think, around the country, but there was one definitely in Columbus. And we were talking about health care reform. And everyone said, the idea was to come forward with some proposals for health care reform. And someone said, well, I don't think we need to do this because there is a promise that health care reform is going to be undertaken at the federal level. You know?
Right.
And everybody said, oh, sure, well, that's a good idea. Let's wait a little while.
Yes.
And we waited and waited and waited.
And that's the thing that we get, you know, is before we got it from the state legislature, well, we want to wait and see what the federal level does, and stuff like that. And I said, well, okay, but remember, people are dying while we're waiting.
Yes.
As long as it's not you, it's okay, though, huh? You know.
Well, 12 years ago, Bob Smitty said to me, we're going to get single payer this year in Ohio if we all work hard and work together. And I had just retired from paid work and was anxious to get things organized in the house. But I said, well, you know, if we're going to get it this year and we all pitch in, I have to do this. I have to just let my personal stuff wait.
And how long ago was that?
And so that was 12 years ago. But Bob Smitty was a great leader and educator and artist and playwright in our state, and SPAN does something wonderful in his memory.
He was originally from Cleveland.
Yes,
Debbie.
yes,
Yes.
I
You
know.
probably knew him.
Yes.
I didn't know him up in Cleveland, but I did know he was from Cleveland,
Right.
and that did a lot of work up in Cleveland
Yes.
and stuff. But
Well, you know, I'd like to mention some other historic people, especially because today is the last day, and of course I mentioned this on the air. It's not going to help anyone because it's not going to be on the air today, but today is the last day of Ken Burns' Civil War series, the new
We were
Civil
watching
War
that.
series. Really a wonderful, you know, wonderful in its terrible way of reminding us of the Civil War, and, you know, 700,000 dead, more than in all the other wars that have been fought in America. And one of the people who's an Ohio, originally an Ohio woman, who's mentioned in profiles of Ohio women, is Mary Ann Ball Bickerdike, who was a nurse during the Civil War. During the whole time of the Civil War, she became a volunteer in Illinois, where she was living at the time, and she later went to many of the battlefields, and she was just recognized as an angel of the Civil War battlefields. And one other woman we should remember, because she has a birthday coming up in just a couple of days, maybe probably by the time that this show airs, and that is Margaret Sanger. Margaret Sanger was a nurse in the 100 years ago, and she was the one who first had a Planned Parenthood. She was later the founder of Planned Parenthood, a similar clinic in Brooklyn, which was soon closed, you know, obscene.
Oh, yeah.
They're talking about birth control. They're talking about contraception.
Women's bodies.
Women's bodies. No, you know.
The deep,
But
dark, dirty.
Margaret Sanger was born in 1879, and she was still very much on the scene when I remember visiting Planned Parenthood in 1954. She was still alive in those days. A wonderful person in the provision of health care, Margaret Sanger. So I want to thank very much both Arlene Sheak, who is the local representative, one of 7 in the state of Ohio. She's the local representative for SPAN, Single Payer Action Network in Ohio, here in our territory, and Debbie Silverstein, who is the overall person for SPAN Ohio,
State Director, yes.
Single Payer Action Network
Yes.
Ohio. And I hope that people will have learned a great deal from Debbie and Arlene about SPAN, and be sure you go to the website for SPAN Ohio, and maybe come to the meeting October 16th, which will be held in Columbus on St. Clair Avenue on October 16th in the evening. So do want to thank you both very much for being on my show.
Well, thank you for having us. Yeah.
This is Lois Whaley for Women Today and Yesterday.